Welcome to the Tobacco Online Policy Seminar, TOPS. Thank you for joining us today. I am Samuel Asare, a Principal Scientist of Tobacco Control Research at the American Cancer Society. TOPS is organized by Mike Pesco at Georgia State University, C. Shen at The Ohio State University, Michael Darden at Johns Hopkins University, and Jamie Hartman-Boyce at University of Oxford. The seminar will be 1 hour with questions from the moderator and discussant. The audience may post questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable comments. Please keep the comments professional and related to the research being discussed. Comments that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your comments are very much appreciated. This presentation is being video recorded and will be made available along with the presentation slides on TOPS website, tobaccopolicy.org. I will turn the presentation over to today's moderator, C. Shen from Ohio State University, to introduce our speaker.
Thank you. Today, we kick off our summer and fall 2023 season with a single paper presentation by Andrea Titus, entitled A Matched Analysis of the Association Between Federally Mandated Smoke-Free Housing Policies and Health Outcomes Among Medicaid-Enrolled Children in Subsidized Housing, New York City, 2015 to 2019. Dr. Andrea Titus is an assistant professor in the Division of Epidemiology, Department of Population Health at the NYU Grossman School of Medicine. As a social epidemiologist, her research focuses on the social determinants of chronic disease, including investigating how tobacco control policies impact disparities in smoking behavior, air quality, and downstream health outcomes. Her current work includes using quasi-experimental study designs to examine associations between smoke-free housing policies and pediatric and adult health outcomes in New York City. She received her PhD from the University of Michigan and her MPP from Harvard University's John F. Kennedy School of Government. Our discussant today is Dr. Alex Lieber, Assistant Professor at Georgetown University. Dr. Andrea Titus, thank you for presenting for us today.
Thank you so much. I'm going to go ahead and share my screen. All right, thank you so much for the opportunity to present today. I'm excited to share some of our work on the impacts of smoke-free housing policies in New York City on pediatric health outcomes. Funding for this work was from the National Cancer Institute. I completed much of the analysis as a postdoc, and so I was also funded through a training grant through the Agency for Healthcare Research and Quality. I've listed my other funding sources over the prior 10 years, and I have never received funding from the tobacco industry. This analysis includes the use of Medicaid data from the New York State Department of Health, so I've just included their disclaimer as well associated with the use of that data. So as I'm sure everyone on the call is aware, there are many health outcomes associated with secondhand smoke exposure. Secondhand smoke affects the health of adults and children in the US and worldwide. Among adults in the United States, exposure is associated with nearly 34,000 heart disease deaths annually and more than 7,300 lung cancer deaths annually. And among children, secondhand smoke exposure is associated with asthma attacks, respiratory infections, ear infections, and SIDS, among other health outcomes. In the US, we see a very strong socioeconomic gradient with regard to the prevalence of secondhand smoke exposure. So this is some data from the National Health and Nutrition Examination Survey. They collect biomarker information on recent secondhand smoke exposure in the form of serum cotinine. So the graph on the left shows a prevalence of secondhand smoke exposure among kids 3 to 11 years old, and on the right, 12 to 17 years old. And what we see is that among children who live in households earning less than 100% of the federal poverty level, prevalence of secondhand smoke exposure is over 50% among those children. And that goes down as you sort of climb up the income gradient. Among families who earn more than 400% of the federal poverty level, we see rates of secondhand smoke exposure around 15 to 17%. So a very strong socioeconomic gradient. We also see differences in the prevalence of exposure by race and ethnicity. And these prevalences differ a little bit from patterns that we might see with regard to adult smoking prevalence. So among children in particular, non-Hispanic Black children, over half of them are exposed to recent secondhand smoke or have evidence of recent secondhand smoke exposure compared to lower prevalence among other racial and ethnic groups. And there's been a fair amount of work trying to look into what drives inequities in secondhand smoke exposure prevalence. And one thing that we do know is that smoking in the home is a major driver of exposure to secondhand smoke. So these graphs are also from NHANES, and they show the prevalence of secondhand smoke exposure among kids ages 3 to 11 and 12 to 17 by the number of smokers in the home. So among children who live in a home without any smokers in the home, rates of secondhand smoke exposure are around 20 to 25%. That climbs to 60 to 70% if they live with one smoker in the home, to over 80% among children who live with 2 or more smokers in the household. And even if children don't live in a household with an adult who smokes, they still may be at risk of secondhand smoke exposure in their home environment if they live in multi-unit housing, and that multi-unit housing doesn't have a smoke-free policy. So this is a paper from 2010 that tracks PM 2.5 levels over time in multiple apartments. The top line shows PM 2.5 levels in an apartment with someone who smokes inside. And you can see how PM 2.5 kind of tracks with the lighting of a combustible cigarette. So we see PM 2.5 levels jump when the cigarette is lit and go back down after a period of time. The next line down on the graph with the circles is the non-smoking apartment next door. And so PM 2.5 levels are lower in that apartment, but they also track with the combustible cigarette use in the apartment next door. So multi-unit housing and residents of multi-unit housing are at higher risk for secondhand smoke, again, if there is no smoke-free policy in place in these environments. So in response to all of these factors, the sort of strong socioeconomic gradient in secondhand smoke exposure, the risk to children and adults, if you live with someone who smokes, the transfer of secondhand smoke between units within multi-unit housing. In 2016, the Department of Housing and Urban Development in the US issued a rule that prohibited smoking in public housing developments. And the text of the rule is that public housing authorities must design and implement a policy prohibiting the use of prohibited tobacco products in all public housing living units and interior areas, as well as in outdoor areas within 25 feet from public housing and administrative office buildings in which public housing is located. So this is a fairly comprehensive rule in that it must include all indoor areas, including inside apartments, as well as this buffer of 25 feet around public housing developments. And it has the potential to have a wide-ranging impact since nearly 1 million households in the United States live in public housing developments. And I'll just note here that the text of the rule is such that it must include at a minimum items that involve the burning of tobacco products. So that includes things like cigarettes, cigars, pipes, and other products along those lines. HUD required that the policy had to be implemented by July 31st, 2018. We have some prior evidence with regard to the impacts of smoke-free housing policies. Most of these studies have focused on air quality. And the evidence on air quality is somewhat mixed. So in Philadelphia Housing Authority, for example, smoke-free housing was associated with a decrease in airborne nicotine in public areas in the year following implementation. There have been a number of papers that have focused on smoke-free housing in the Boston Housing Authority with somewhat mixed results. So there's been some evidence of reductions in PM 2.5. However, one study also found that airborne nicotine in apartments without resident smokers declined at similar rates between Boston Housing Authority and comparison developments that didn't have the same smoke-free policy. In New York City, our team has done some work tracking air quality, and we'll come back to this a little later in the presentation to contextualize the health outcome findings. But our team found that there was no difference in air quality trends between New York City Housing Authority or NYCHA developments and comparison developments in the early post-policy period. Some of our more recent work focused on longer term trends has revealed declines in airborne nicotine in NYCHA hallways in particular compared to our comparison developments. And then in Norfolk, Virginia, somewhat counterintuitively, they found that a smoke-free housing policy was associated with increased PM 2.5 and airborne nicotine in a year following implementation. So somewhat mixed evidence on the impact of these policies on air quality. There's very little prior literature on the health effects of smoke-free housing and public housing developments. In Colorado, a smoke-free housing policy was associated with reduction in self-reported breathing problems, but very few papers have focused on this topic, and in particular, very few papers with a comparison group where you can actually look at changes over time relative to developments or multi-unit housing that maybe didn't have these policies in place. That being said, smoke-free housing is not the only type of smoke-free policy. We also have smoke-free policies and laws in workplaces, other types of public areas. So there has been some work on those types of policies and health outcomes. So this is results from a meta-analysis of smoke-free legislation in workplaces and other public areas and pediatric asthma hospitalizations. And they found that smoke-free legislation in workplaces and public areas was associated with a 10.1% reduction in hospitalizations for pediatric asthma. And this was from 3 papers. They also found a significant association between smoke-free policies and preterm birth, but not for low birth weight. So there's some sort of prior justification for thinking that smoke-free housing policies may have impacts on downstream health outcomes through impacting air quality, but there's been relatively little prior work in this space specifically. So the analytic goal of our project was to use Medicaid claims data to evaluate the impact of smoke-free public housing policies on healthcare visits associated with asthma, lower respiratory infections, and upper respiratory infections among children living in New York City Housing Authority or NYCHA buildings. Our study period was November 1st, 2015 through December 31st, 2019, with the intervention in July of 2018. So our post-intervention period would begin in August 2018. So we had about 33 months of pre-policy data and 17 months of post-policy data. And our overall design was to treat the smoke-free housing policy as a quasi-experiment by comparing changes over time in secondhand smoke-sensitive pediatric health outcomes among residents living in NYCHA housing, matched to residents living in other types of housing, subsidized housing in New York City that was not subject to the HUD rule. So these other types of subsidized housing programs could include other HUD finance programs. So these are programs like the Section 8 Housing Voucher Program, property tax incentive programs tied to the provision of low-income housing, zoning initiatives, or other city and state housing subsidization programs. We also had as a secondary analysis to stratify our sample by age group, ages 0 to 2, 3 to 6, and 7 to 15. And we were interested in that study question, knowing that there are sort of differential drivers of some of these outcomes in different age groups. Thinking about asthma in particular, we see kind of different patterns of asthma in school-age children versus non-school-age children. So we had as a secondary analysis this age group stratification. There are a couple of advantages to evaluating smoke-free housing policies in New York City in particular. One is that New York City has a particularly large population of residents who live in subsidized housing. The New York City Housing Authority is home to 1 in 17 New Yorkers, and over 500,000 New York residents participate in NYCHA affordable housing programs. In addition to the large population in these subsidized housing developments, we also have fairly detailed municipal data sets that we can use to characterize the local built environment. So I've just included a screenshot of one of these resources here. This is the coredata.nyc resource from the NYU Furman Center. They have mapped and geocoded all of the subsidized housing developments, including NYCHA housing in New York City. You can access this data in a tabular format, in a visual format. click on a development, see what year it was built, what program it's affiliated with. And so this is really helpful for leaking this sort of information with other types of administrative data. I'm not going to spend too much time on the geocoding processes. As I just mentioned, we had addresses of subsidized housing developments from the Furman Center and coredata.nyc. They had used a NYC GBET GeoSupport geocoding application to map these addresses to what's called a borough block lot within New York City. That is a unique tax lot identifier. We also had residential address information in Medicaid enrollment files. And so our group was able to use the same geocoding application to take those residential addresses and also map them to borough block lots. So we were able to identify which children who were enrolled in Medicaid lived in a BBL that was associated with one of these subsidized housing developments, whether that's NYCHA or another type of subsidized housing development. We also mapped those BBLs to census block groups to bring in some other information from the census block group area, including demographic and economic factors and other aspects of the environment. And we did that by using a data set called the NYC Pluto data. Our primary criteria for inclusion at baseline, which again was November 1st, 2015, was that children had to be enrolled in Medicaid in New York City at that time point. They had to be between the ages of 0 and 15 with a residential address mapped to public or other eligible subsidized housing at the BBL level. And they could not be dually eligible for Medicaid and Medicare. And that was a very, very small number of children who were dually eligible. Our eligible N for our primary analysis is at the bottom of the slide in the table. So in our unmatched sample, we had just over 70,000 children living in NYCHA developments, over 100,000 children living in these comparison developments, which were other subsidized housing, other types of subsidized housing. I'm going to talk more about the matching process in just a minute. But as a result of the matching process, we were able to retain the vast majority of the NYCHA sample. We matched with replacement, so our comparison population was just a subset of the overall comparison population, and we ended up with over 40,000 in our comparison population in the final match sample. Our outcomes were outpatient, and these were non-ED outpatient visits, and ED visits with any diagnosis code indicating asthma, upper respiratory infections, and lower respiratory infections. So we looked at each of these health outcomes across the 2 care settings, and we adapted our ICD-10 code lists from the Global Burden of Disease study. I included just a couple of figures here just to show pre-intervention outcome trends in outpatient visits in particular. And this is in our unmatched sample, looking across our 3 outcome conditions, asthma, LRIs, and URIs. The rates among children who live in NYCHA developments are on the green line with the larger dashes, and then our children who lived in other subsidized housing developments are the purple line, the solid line. And then just for comparison purposes, we included children in the rest of New York City who were not living in any type of subsidized housing, and that's the blue dashed line. So you can see that children in other subsidized housing, their rates of healthcare encounters for these outcome conditions are much closer to the rates among the children living in NYCHA developments than we would see if we just were to look across New York City as a whole. So there's some differences in terms of asthma visits. The highest rate of visits is among children living in NYCHA developments. Then we see children living in other types of subsidized housing, followed by the rest of New York City. But the rates are very similar for children living in NYCHA developments or other subsidized housing developments if we look at respiratory infections, and certainly much closer than if we were to look at the rest of New York City. So this made us sort of feel more confident that by restricting to other types of subsidized housing, we were selecting a comparison population that was much closer to children living in the NYCHA developments. Covariates that we considered in our matching process included some demographic factors such as age and sex and race ethnicity, aspects of medical history, including disability status, history of a chronic condition, Medicaid enrollment history. So anytime we're using these administrative data sources, we have to think very carefully about who is enrolled at what time, and whether we're picking up actual rates of an outcome or actual disease burden versus just enrollment changes over time. So we did consider Medicaid enrollment and the total months of Medicaid enrollment over the pre-intervention period as an important covariate. And then we also included some characteristics of the built environment and the local neighborhood, including presence of a high rise within the tax lot and some census block group demographic and economic characteristics. Individual level covariates were from the Medicaid data set. Some of these other covariates at the block group and BBL level were from the Pluto data set that I mentioned earlier and the American Community Survey. Our matching strategy was conducted in multiple stages. So I mentioned earlier that we were interested in looking at associations between the smoke-free housing policy and our health outcomes within our full sample. And we also had pre-specified an effect modification analysis where we stratified by age group. So we wanted to match in such a way where we would achieve balance with regard to our covariates in the full sample, but also across subgroups, which isn't guaranteed in a kind of a standard matching process. So we did this matching in multiple stages. We did 5-to-1 nearest neighbor Mahalanobis distance matching with replacement. We exactly matched on age category, race, ethnicity, sex, and disability status. And then within these exactly matched groups, we did the MD matching using the other baseline covariates and a propensity score for living in a NYCHA development based on all of the specified covariates on the prior slide, except for age group. Then to improve the balance within the age groups, we used a lasso procedure to identify important interactions between age group and covariates. And I should say that this process is outlined in the source listed at the bottom of the slide. It's also at the end of the presentation. That's really meant to optimize, again, that balance within the full sample and then balance across the subgroups that you're interested in examining for effect modification. So we implemented this lasso procedure to identify interactions between age group and covariates, and then we re-estimated our propensity score within the matched data, and we calculated overlap weights based on that re-estimated propensity score. Once we went through that matching process, the statistical analysis was fairly straightforward. We did a match difference and difference analysis with policy introduction again in July of 2018. We used GE models with a negative binomial distribution, including an autoregressive correlation structure, robust standard errors, and the overlap weights, which were generated from the matching process. So the equation and formula is on the slide, where Y is the rate of visits for the specified health outcome for an individual I at time T. We had an indicator variable for whether or not a child lived in a NYCHA development, an indicator variable for the post-policy time period, and then we included an interaction between the NYCHA variable and the post-policy time period variable. We also did include the covariates that we used in the matching process in the outcome model as well, with the exception of total months of Medicaid enrollment. So I'm going to go one more slide and then I'll take a pause for questions. But just to wrap up the methods portion of the paper, we did several additional analyses and robustness checks. We had sensitivity analyses and alternative model specifications that included matching on quarterly rates of our health outcomes in the pre-intervention period, defining our outcomes using primary diagnosis codes rather than any diagnosis code, restricting our analysis to non-movers over the follow-up period. So we initially based our eligibility on residential address at baseline, but we did have updated address information across the study period. So we were able to restrict to children who stayed within the same BBL over the study period. And therefore we would have confidence that they were exposed to the NYCHA policy or not over the full study period. We restricted our analysis to continuously enrolled children, again, to address that the potential for, kind of differential churn or disenrollment over time impacting study results. And then we also included a 3-month washout period following policy introduction under the assumption that even though the policy was implemented in July of 2018, the effects might not have been immediate. We were interested in doing some robustness checks to kind of investigate the extent to which our results may be due to something like residual confounding. We evaluated associations in a placebo year prior to policy introduction. So in the year prior to 2018, July 2018, we sort of set that as the treatment year instead to see if, we might pick up sort of differential trends in the pre-policy time period. We also examined injuries as a negative control outcome, and I will talk a little bit more about negative controls a little bit later in the presentation. But the idea here is that we wanted to pick a health outcome that would be sensitive to general housing conditions, but that would not be impacted by the smoke-free housing policy. So we picked injuries as our negative control outcome. And the assumption here is that if we see an association between the smoke-free housing policy and the negative control outcome, in this case, injuries, that may be an indication that our primary analysis is impacted by residual confounding. And if we don't see an association, that's in line with our understanding and what we would expect. So I'll talk a little bit more about that analysis in a few minutes. But let me pause here for any questions at this point.
Thank you, Andrea. Let's turn to our discussion today, Dr. Alex Lieber, to see whether he has any questions or comments.
So first, Andrea, I have to say you did so much amazing work to get all this data together and create a matched sample and do this analysis. I think there are some questions about first, the NYHCA policy came into effect in July 2018, and housing authorities were allowed to have smoke-free policies prior to that date. Did you do any work to figure out if other New York area subsidized housing or even housing developments within NYCHA had smoke-free housing prior to the 2018 date?
Yeah, that's a great question. And the answer is that almost certainly there are other smoke-free housing policies at play here. And NYCHA also did have a much more limited policy prior to July 2018. So this was a more comprehensive policy that covered more types of indoor areas and the outdoor buffer as well. One of the limitations of the analysis is that we can't guarantee that the comparison population doesn't also have smoke-free housing policies. We don't have a comprehensive database of all of the multi-unit housing policies in New York City. We're sort of making an assumption that there wasn't a sort of a large uptake and implementation of these policies during our follow-up period, because that could bias our results. But that is a limitation, especially with regard to the comparison population.
Yeah. There are some questions about compliance, and could you comment on how was this policy enforced? Were you privy to any data on people who were penalized for violating it in the aftermath, in terms of what did it actually change on the ground?
Yeah, another wonderful question, and something I have some information on later in the presentation as well. So part of this R01 that funded this project was, quantitative analysis of health outcomes, air quality monitoring, and also an implementation evaluation that was largely qualitative, working with NYCHA, focus groups with residents, for example, to really understand on the ground what the policy looked like and what the implementation process looked like. So we know that there were a lot of challenges around compliance and enforcement, particularly in the early stages of the policy. And this particular analysis is focused on kind of an early post-intervention period. So just the first 17 months post-policy. So it's a challenge. There in our focus groups with residents, and I should say I was not directly involved with the qualitative component of this project at all, but there are published papers on this aspect of it. But some of the residents felt that the policy was kind of overreaching by covering or prohibiting smoking within apartments. Residents were engaged in the policy implementation process, but still, like, not everyone knew about the actual policy implementation. Some felt that there was a lack of support for cessation, which I think is a really important wraparound service that could also accompany this type of policy. In general, I think HUD issued this rule, but that didn't necessarily mean that there were a lot of resources to go into the, compliance portion of it or the other services that may have helped support residents in complying with the policy. So that is very much an ongoing process. We included this 3-month washout period, but we know we actually probably need a lot longer washout period than that to really start picking up maybe some of the impacts of the policy. And I'm going to show some data a little bit later on air quality that gets into that issue a little bit more, but many ongoing challenges with enforcement and compliance for sure to this point.
Yeah, and I have maybe 1 or 2 more questions, but so there was differences in the baseline rates of illness that were quite large for like upper respiratory infections. I thought that was really quite surprising, but then the pattern sort of flipped for asthma. Do you have any reasons why there might have been pre-policy differences in having these infections? Do you think it had something to do with secondhand smoke exposure, something about the parents, something I even the presence of high rises, which seems to be a really weird difference between the control and treatment groups. What would have caused that?
Yeah, so I think for the respiratory infections, if we're just thinking about the NYCHA population and our comparison population, the trends are very similar. With asthma, there's a little bit more of a difference. And then there's a large, I can go back maybe just briefly. There's a large gap when we think about the rest of the New York City pediatric population. And I'm showing just outpatient here. And one thing that may be kind of interesting to note is that for the NYCHA and the other subsidized housing population, the rates are generally lower than the rest of New York City. If I were to show ED visits, which was our other outcome, like that would flip. So we're also picking up some differences in just healthcare utilization and differences across care settings that children in these different types of housing developments may reflect. We do see these differences between NYCHA and the comparison population with regard to asthma. And that's one of the reasons that we really did want to do the matching process and try to see if we could kind of minimize those differences in the pre-intervention policy period. But yeah, depending on the care setting, I think you'll see like very different trends. I didn't want to show all of them for the sake of time.
All right. Well, thank you for a wonderful first part of the discussion. I'm going to kick it back to C.
Thank you, Alex. We have many questions from the audience. So first, let me start with a question from Mike Cummings. He asked to have household economic disparities in secondhand smoke exposure widened over time. I think this was earlier in your presentation.
Yeah, that's a great question. I just showed like a static period in time. And we do know that secondhand smoke in general prevalence has declined over time. I'm not sure about the trends with regard to inequities over time. And it may depend on the scale you're looking at, kind of relative scale or absolute scale. We have seen things go down in all groups, but have they gone down, sort of equally? I'm not sure. That's a very good question.
Thank you. I'll try to summarize 2 questions, both from Norbert Schmidt and Lydia Motoya, and both ask about enforcement. Do you know how many families were evicted for violating the policy and whether there were graded levels of enforcement, for example, asking them or helping them to get a nicotine replacement therapy or other services to quit before eviction?
Mm-hmm. So it's a graduated enforcement policy. To the best of my knowledge, at the time of this analysis, I don't believe anybody had been evicted for violating this policy because it is sort of a longer implementation process that does involve resident engagement, and certainly there are like many other services that would be good to connect people with, prior to reaching the stage of lease termination. So again, this was a very early post-policy period, and I think we're at the very early stages of the enforcement and compliance track as well, and that may evolve over time. I know there's been a lot of challenges around residents not feeling like there are sufficient links to things like cessation resources to help them quit. this is an opportunity. I think this type of policy is an opportunity to think about how to support people in their cessation efforts, because it, you know, fundamentally like makes smoking more inconvenient also, in addition to, you know, there being other potential consequences. So there are some colleagues, I believe, at Columbia who are examining, you know, other types of interventions that may help with cessation support. But I know from the you know, from the NYCHA experience, that there's just been limited resources to sort of do everything that we would like to see with the NYCHA smoke-free housing policy. And so we're kind of in the process of exploring other ways to support residents. And also exploring, you know, how compliance efforts have changed over time, and that's been the focus of the implementation work. And there's been some great papers on the implementation process that I encourage you to take a look at.
Yeah, there is a follow-up comment, maybe teaming up with Quick Lines. I think that's a good suggestion.
Exactly.
Yes, one last question from Mike Cummings again. Have you looked at NYC survey that assesses smoke-free home policy rules? You should be able to stratify by whether the policies vary by type of household, public multi-unit, dwelling versus other types. I think this is about stratification of your analysis by the household types.
By household, yeah, I'm not sure I'm familiar with that data set. Was it the NYC survey? Was that what?
Yes, I think he mentioned an NYC survey, but I'm not sure which one he is referring to. Maybe you can contact him later after the presentation.
Yeah, I think that, yeah, that'd be very helpful to connect. And I will say we have information on what types of subsidized housing developments are in the comparison population. It's a pretty heterogeneous mix. We tried at one point to just look at Section 8 housing voucher programs, for example, in our comparison group, as they might be the most similar to the NYCHA population, but we were a little bit underpowered in that type of analysis. So we were kind of weighing, you know, how to filter those subsidized housing developments appropriately for this project. But yeah, I'd love to connect afterwards.
Thank you. That's the last. Please continue. Thanks.
Okay, great. So I'm going to move into the results. These are some descriptive characteristics of our analytic sample. These are standardized mean differences for key covariates in the unmatched and the matched sample. So the unmatched sample is represented in the sort of orange, red dots, and the matched samples, the blue dots. I'll just point out that we had some differences between our comparison population and our population that lived in NYCHA developments with regard to race and ethnicity, disability status, and also whether or not there was a high rise within the BBL. And we did select that variable purposefully, thinking that, you know, high rises represent sort of a certain type of dense multi-unit housing, and maybe particularly indicative of transfer between units with regard to secondhand smoke. So we did see big differences between our groups, at least in the initial unmatched sample. And then when we matched, as you might expect with the overlap weighting approach, we had a very good balance across these covariates within our matched sample. This table is just showing our difference in difference coefficient estimates comparing post-intervention outcome rates between children in NYCHA developments and children in other types of subsidized housing. So this is interpreting the coefficient term in the difference, or the interaction term in the difference in difference model. All of these incident rate ratios are relatively small in magnitude. The association with upper respiratory infections in the outpatient setting was statistically significant, but again, very small magnitude. And just to sort of underscore, you know, how small it is, these are the trends in mean quarterly outpatient URI visits per 1,000 children within our matched sample over time. You can see where the policy was introduced in August 2018. It's really barely discernible, the difference between the two lines. So even though it's, you know, statistically significant at that 0.05 level, we did not want to overinterpret this result. And I'll also just point out it's statistically significant in an unexpected direction that would suggest higher rates of URI visits among children in NYCHA developments associated with the policy. So I want to talk a little bit more about like sort of how we contextualize and thought about this finding. We generally saw consistent results, at least directionally, across model specifications. When we looked at our sample and restricted our outcome definitions to primary diagnosis codes, we found that the policy was associated with higher rates of asthma ED visits. So again, seeing maybe a signal here, but not in the direction that we would expect. We would expect the policy to be associated with lower rates of these healthcare encounters, and instead we see a couple of signals that maybe they're associated with modestly higher rates of these healthcare encounters. So for that reason, we were especially interested in our robustness checks, which may help us investigate the potential for residual confounding or other types of bias that would lead to these unexpected results. We found no associations between the policy and health outcomes in our placebo year, and we saw no association with injuries as a negative control outcome. And just to spend 1 minute here thinking about negative controls, I'm an epidemiologist, so I like working with these directed acyclic graphs or DAGs. All of the arrows in this diagram represent kind of a causal or an association between variables. So we expect our smoke-free policy to be associated with health outcomes. We have our measured confounders, which are represented with the letter C. And we also might be worried about unmeasured confounders represented with this letter U here. And unmeasured confounders may be other aspects of the housing environment, for example, that would be associated with living in a NYCHA building and associated with our health outcomes. So the idea behind a negative control is that we can pick an outcome that shares the same confounding structure as our relationship of interest, but that isn't directly impacted by the smoke-free housing policy. So in this case, if we were worried about other unmeasured aspects of housing environments as a source of residual confounding, we might pick a negative control outcome that is injuries. Injuries would be impacted by other unmeasured aspects of the housing environment, but wouldn't be directly impacted by the smoke-free policy. So if we see associations between the smoke-free policy and injuries, we would attribute them to unmeasured confounding, and we would be worried that that would be impacting results in our main analysis. But we did not see associations between the smoke-free policy and injuries. So I want to just spend a couple of minutes interpreting these results. I think the big takeaway here is that our analysis does not suggest that the policy was associated with lower rates of healthcare encounters for secondhand smoke sensitive conditions among Medicaid-enrolled children in the early post-policy period. The statistically significant association with URIs, it was very small in magnitude. The difference between the groups comparing the pre and post-policy periods was just 0.8 visits per 1,000 children per month. So we really don't want to overinterpret that. As I mentioned earlier, the qualitative component of this project suggests ongoing challenges with policy implementation and enforcement. And the lack of associations with health outcomes in this early post-policy period is also consistent with our air quality findings. So I'm showing here a figure from air quality research led by El Anastasio, who's affiliated with our team as well. And this is a graph showing geometric mean cotinine levels in NYCHA housing hallways compared to control hallways in Section 8 buildings. And you can see in this early post-policy period, there's not much of a discernible trend with regard to reductions in airborne nicotine in NYCHA developments compared to the comparison developments. The end of our study period is right around December 2019. We have since seen trends that suggest that airborne nicotine in hallways in NYCHA buildings is decreasing relative to what we see in the comparison developments. So I think that this is an indication that we need to continue to do this health outcome monitoring, but these early post-policy results are consistent with what we saw in the early post-policy period with regard to air quality as well. Since we did have a couple of counterintuitive findings, we also explored in the paper, what could be driving those. It could, of course, just be randomness. It could also be residual confounding or some other kind of statistical artifact. So I mentioned the potential for deterioration of housing environments over time or other secular trends that might differentially impact NYCHA or other subsidized housing developments. Our robustness checks were designed to assess this, but of course, we cannot fully rule it out. We also could have experienced differential churn or enrollment over time between our NYCHA population and our population in the comparison housing developments. We had a fixed cohort, so the proportion of the original sample that was enrolled did go down over the course of the study period. We had about 70 to 80% of the original cohort still enrolled by the end of the study period. And the levels of enrollment were very similar between children in NYCHA developments and children in the comparison population, but we don't know who is remaining in the sample. We didn't have a clear way to test that. So it could be that the children who remained in the NYCHA cohort could be sicker or just be higher utilizers of the healthcare system, for example, and that could also drive counterintuitive results. We wanted to be open to the possibility, especially as we continue this health outcome monitoring and air quality monitoring, also that the policy could have unpredictable impacts on smoking behavior, air quality, and downstream health outcomes. So I mentioned earlier that there was one prior smoke-free housing evaluation that found increases in PM 2.5 and secondhand smoke following policy introduction, and this was in Norfolk, Virginia. They actually found, if they looked just immediately following the smoke-free housing policy introduction, they found reductions in PM 2.5 and nicotine. But 1 year following, there were increases in PM 2.5 and airborne nicotine relative to the pre-policy period. It is possible that these policies may change smoking behavior, may encourage smokers to use cigarettes in areas that are less likely to be enforced, such as inside of their apartments or inside of certain common areas where there is less likely to be enforcement taking place. In that case, we may see increases or worsening of air quality among certain populations, and we can't rule that out. So I think that that's an important area to continue to investigate. Strengths of the study include the large population of individuals living in NYCHA or other subsidized housing developments. This supported our quasi-experimental study design and our statistical power. We had multiple secondary and sensitivity analyses. Within the context of the broader R01, we were able to do this health outcome monitoring and couple that with air quality monitoring and qualitative research, which was really helpful for contextualizing the findings. We also had a number of limitations, including limited post-policy period data, the potential for residual confounding. I mentioned this earlier, but our comparison population was likely very heterogeneous, a mix of many different types of subsidized housing programs or children living in BBLs with and without subsidized housing. And one of the maybe disadvantages to matching or doing this distance matching is it's hard to characterize who actually ends up in your sample. And we also couldn't rule out whether other subsidized housing developments may have had independent smoke-free housing policies, which we touched on earlier as well. So in New York City, the introduction of a smoke-free policy was not associated with lower rates of Medicaid claims for any of these pediatric outcomes in the early post-policy period. Exposure to the smoke-free policy was associated with slightly higher rates of outpatient claims for upper respiratory infections, but changes were very modest. Air quality monitoring and qualitative research highlights the need for ongoing health outcome research and policy implementation support. So as I mentioned earlier and showed earlier, the 3-year air quality data does suggest that air nicotine is trending downward in NYCHA hallways compared to our Section 8 control group for that analysis. Though I'll note that the trend is not as apparent in non-smoking apartments or stairwells, which were the other areas where we had monitors. Just want to wrap up with a couple of policy and research implications. With regard to the policy implications, addressing high levels of secondhand smoke exposure in multifamily housing remains a priority, given disparities in respiratory health outcomes across housing environments. Policy priorities include supporting the implementation of smoke-free housing policies, including improving access to cessation support and further engaging residents in implementation. And smoke-free housing is one aspect of a wider healthy homes agenda, which also includes investing to improve environmental and structural health of buildings. With regard to research implications, we are continuing to monitor air quality in building common areas over time. We're in a no-cost extension portion of our R01 now, and still looking at air quality, particularly in building common areas, so that we can get a longer-term view of the policy impact. Given the evolving implementation landscape, we're also examining health outcome trends over a longer post-policy period, so through 2022. So we currently have analyses underway looking at pediatric health outcomes and adult health outcomes, such as respiratory infections and cardiovascular disease outcomes, using all payer claims data. And as I have mentioned previously as well, this mixed methods evaluation that includes focus on the policy implementation process has really been key to contextualizing our findings. So I want to wrap up by just acknowledging the many collaborators for this project, including academic collaborators at NYU and elsewhere, our collaborators at NYCHA and at the Department of Health as well. I have some references and I am happy to take any questions.
Thank you, Andrea. Very interesting findings. Let's turn to Alex for his comments and questions. Thanks.
So overall, this is a really impressive study. It's counterintuitive in what it finds, and maybe in the public health community, we're always a little disappointed when big interventions don't find a positive impact. We can't find necessarily, I mean, the really significant one was a tiny harm, which is a bit discouraging sometimes, but it's really great to be see a study that's so thorough with its methods and so intentional in its design come to, a conclusion that the data led it to. And it's always impressive to see that. This particular area of policy is always marked by a real distinct tension between two fields in public health. One that looks at indoor air quality and preventing exposure from secondhand smoke, and another that is working with a housing insecure population that desperately needs to stay in whatever kind of affordable and decent housing they can. And when we put them at tension, it creates, if not awkwardness, then it creates a really interesting policy implementation problem where we may not be so comfortable kicking someone out of their house as we are telling someone to leave a bar if they light up a cigarette in a bar. And I want to know sort of how do you view your findings contributing to this quite deep tension between housing security and secondhand smoke prevention, especially exposure with children. How do you see these policies, your work in filling in that context?
Mm-hmm. I think that that's a really important aspect of the conversation to acknowledge. And I think one point that I think is important to make is that most residents do support smoke-free housing policies. So, it's sort of working with residents to understand their priorities, and nobody wants to see people being evicted from public housing, of course. So I think that the focus of the conversation really needs to be around providing the support for people to comply with the policy, or to recognize this as an opportunity to maybe quit smoking if that's something that they're interested in as well. I think that this is sort of an ongoing discussion, but there are other policies as well, things that people are permitted or not permitted to do in housing developments. It's not unique to secondhand smoke exposure. I think in this case, the risk to kids in particular is clear, who don't have a lot of agency in the situation, but it is a very thorny implementation process, and it creates some thorny situations around the residents as well, maybe not feeling comfortable confronting other residents or encouraging the enforcement of the policy against other residents, for example. And all of these things really, do need to be worked through. But I personally feel like the most important thing that we can do is to continue to engage with the residents around these issues, understand what their priorities are, and to also provide things like cessation support more fully, maybe than we have been able to in the past. And as I mentioned at the end of the slide, I think that this is just one aspect of the Healthy Homes agenda. And I think through the qualitative research, it also comes out that residents have many priorities when it comes to safe and healthy housing. And all of those things, need to be addressed, programmatically and through the budget as well. And it's important to, make sure that the buildings are safe and structurally sound. And this is just one component of that. So I do believe that there's a lot of work to do, and it's sort of the conversation is broad in the way that you suggested, and also connects to all of these other issues around like housing quality that we have to work on.
There is also an audience, Doug Levy, mentioned that his team examined smoke-free housing in Massachusetts, has found no evidence that smoke-free policies have led to greater transitions, including evictions in public housing. And he also shared a link. Thank you, Doug.
Thank you.
Yeah, and I actually just had one last sort of question, which was about I didn't get to read the Anastasio 2023 study that found that measured actual air quality within these buildings. Why did it take till 2022 to get smoking or to get air quality indexed to the same rates as Section 8 housing in NYCHA housing? Was there a policy change that took longer? Or
I think, yeah, I mean, I think it's reflecting the implementation process. And I should note that we did see those trends in hallways, but it was not replicated in non-smoking apartments or other types of common areas. So that's something we need to disentangle, why hallways and not other areas. As I sort of alluded to at the end of the presentation, like these policies, if they are enforced, probably are changing smoking behavior in ways that we're not anticipating. And it may be displacing smoking behavior to other indoor areas or outdoor areas, which is the intention of the policy. But I think if we believe those results, I would say that that is a reflection of the sort of long tail implementation process and kind of the gaining of steam for that over time. But I think that there's more work to be done to understand the dynamics there, since we only see it in hallways and not as clearly in other places like non-smoking apartments.
Back to you, C.
Yeah, thank you. So we have some questions from the audience. The first one is from Mike Cummings again. Besides additional monitoring to see if a policy effect emerges, what other types of studies might be done? Has anyone done a survey of patients coming to the ER where one could assess household secondhand smoke exposure? Potentially, this could be done using electronic health records.
Yeah, I think that that's a great suggestion. I think there are other very creative ways to look at these health outcomes, and I think there's also the smoking behavior outcomes that could be assessed. Sort of was just alluding to either through primary data collection or through the use of secondary data sources that capture information on housing environments and smoking behavior. So this was a rule that was implemented nationally, not just in New York City. So there should have been public housing developments across the country that were implementing these kinds of policies, and maybe some opportunities to link with other types of data sources that could allow you to look at smoking behavior in particular. I think the use of other types of administrative data would be potentially very helpful if you could capture some aspect of secondhand smoke through exposure through those data sources. I'm less familiar with how one would do that through EHR, but I'd love to think about other creative ways to sort of examine the impacts of these policies.
Thank you. There is another question from Norbert Schmidt. Did you monitor for other sources of PM 2.5, like barbecue and open fires? How prevalent are those sources?
Yeah, so we, in the air quality monitoring portion of the analysis, we looked at PM 2.5, and we also looked at airborne nicotine, which should be more specific to tobacco smoke. PM 2.5, is not as specific to tobacco smoke exposure, but in the context of the difference in difference analysis, we're sort of making an assumption that other contributors to PM 2.5, like traffic related air pollutants or other things that you mentioned, that the trends in those kinds of exposures are similar between the NYCHA population and the comparison population over time. So we don't specifically separate out those types of exposures, and so I think in that sense, we're making that assumption about kind of trends in PM2.5 being similar across groups over time. And then also looking at airborne nicotine as kind of a more specific outcome associated with the tobacco smoke exposure and the smoke-free policy in particular.
Thank you. I think we have time for one last question from Kathleen Hui. She said the health effects of secondhand smoke may take many years to manifest. Can you interpret the findings through previous studies on how long one must be exposed to secondhand smoke to see health impacts? Although the magnitudes you found are small, they might suggest larger future impacts.
Mm-hmm. Yeah, and so that's a great question, and we're quite limited here with the 17 months of post-policy data. And one of the reasons that we're excited to continue this work with longer time period is to take some of those factors into account. So, so we have folks looking at respiratory infections over, 3 or 4 years and really thinking about how long, does it take to kind of reverse the effects of prior secondhand smoke exposure. How long would we expect it to take to see health effects? We picked asthma and respiratory infections in this study because we think they're relatively shorter term, but there also are longer term health effects, things like cancers or other outcomes. So we would be very limited to assess in this type of study. But I think that's really important once we have more post-policy data to really dig into those kinds of questions.
I think we're about time. I'll pass other questions to you later. So let's turn this to our MC to wrap us up. Thank you very much for the great presentation.
Thank you for the opportunity.
We are out of time. Thank you to the presenter, moderator, and discussant. Finally, thank you to the audience of 125 people for your participation. Have a top-notch weekend.